Hello, I am Dr. Lawrence Smith, Dean of the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. Thank you for tuning in to Well Said. In a culture of community, scholarship, and innovation, the Zucker School of Medicine is dedicated to transforming students into doctors who will improve healthcare, inspire change, and better the lives of the people they serve. It is why we are pleased to collaborate with WRHU Radio Hofstra University to bring you a program committed to sharing expert discussion and insight on health and wellness topics important to you. Join us today and each week for a recommended dose of Well Said with your host, Dr. Ira Nash.
Hello, I'm Dr. Ira Nash. Welcome to Well Said. The COVID pandemic arrived in the United States just over 2 years ago, and our understanding of the virus that causes it, our tools for dealing with it, and our attitudes toward it are all profoundly different now than they were when this whole thing started. So we thought it was a good time to get a fresh look at where we are now and where we may be headed. To give us that fresh look, I've asked my colleague Dr. Bruce Farber to come back on the show. I spoke with Dr. Farber early on in the pandemic, and he has been on the front lines ever since. He's an infectious diseases expert and the Chief Public Health and Epidemiology Officer for Northwell Health. He's also a professor of medicine at the Zucker School of Medicine, and as far as I'm concerned, the go-to guy for all things COVID. So I'm delighted that he's agreed to come back on the show. Bruce, welcome back to Well Said.
Thank you, Ira. I'm honored to be with you.
So we certainly have a lot to talk about, and in thinking about how to frame this, I thought maybe we should start with how the disease itself has changed. I mean, we certainly have learned an awful lot about this illness, but it seems like the COVID-19 we're dealing with right now is not the COVID-19 we were dealing with in March of 2020. Do you agree with that?
Oh, 100%. I mean, I think we've had really 4 major waves of COVID. The first 2 were with the ancestral or Wuhan strains. And just when we thought it was over, came the Delta. And Delta was much more contagious than the original Wuhan strain and was, certainly as severe. We went through that. And again, I think we naively thought we're done. And then came Omicron, which was at least 2 times more contagious than the Delta strain, dramatically more contagious than the initial strain. Fortunately, Omicron had an amazing silver lining when it came in December and kind of ended in early February, and that's that despite the level of contagion, it was much less severe. And clearly it was problematic to people who had not been vaccinated, and certainly can cause and did cause many deaths and will continue to. But nevertheless, in people who had gotten vaccinated, and particularly those who got boosted, the morbidity and mortality was a lot lower than with Delta. And the silver lining was that so many people got infected with Omicron that it left us with at least some pretty broad level of immunity among our population. I would point out some amazing factors that at the peak of the Omicron epidemic in January, Ira, 250 million people were getting infected daily across the world.
Oh, my God.
An astronomical number, never seen before with any virus or any infection or anything else. And at least 50 to 60% of the United States has been infected with Omicron, and we're at least getting the dividend of that now.
So let me ask you a couple of questions about that, because I think it leads us potentially in a whole bunch of directions. So first is the illness itself. So when you say it's less severe with the more prevalent strains now than with the original strain, is the disease itself kind of the same but just a lighter version, or is the disease itself kind of something qualitatively different?
Well, it is qualitatively different to some extent. Clearly, the number of people in the ICU, are dramatically lower. The people on ventilators are dramatically lower. The people who need to be in the hospital is lower. There's much less pneumonia. There's much less respiratory failure. The rate of chronic COVID and post-COVID syndromes is not dramatically different, but it is much lower in people who have been vaccinated and boosted than those that have not. And mortality and morbidity rates were lower. It seems to have a shorter incubation period, usually 2 to 3 days, as opposed to the ancestral strains, which were closer to 5 to 8 days. You will remember that the typical person got Delta and the original strain, and then on day 8 suddenly deteriorated.
Right.
And that did not happen nearly to the same degree with Omicron.
There seems to be a lot of, I guess I'll call it popular mythology about the way that viruses evolve, with some people saying that as the virus becomes more contagious, the disease it causes becomes less severe. Is that true, or did we just get lucky with this?
We got lucky, and
okay.
I don't think there's any scientist or virologist who says that there's any reason why mutations that make some virus more likely to adhere with lower inoculums and easier to the mucosa are necessarily going to be less virulent. As a matter of fact, the reason why Omicron was so contagious and less severe is that it did stick much more readily to the upper mucosa and did not adhere as well to the lower bronchial mucosa. But there's no reason that can't happen, and certainly I wouldn't bank on that by any stretch of the imagination.
Yeah, so when you say it stuck to the mucosa, so it was more likely to stay kind of as a head cold than go deeper in the lungs and cause pneumonia and all the terrible complications we saw in the first wave.
Exactly.
Yeah. So the disease is different, caused actually by a mutated virus compared to what we started with. What about our tools for dealing with the illness that people still get? We have a lot more at our disposal now than we had 2 years ago.
Yeah, it's a much better situation, and that's why, barring something terribly unforeseen, I think going forward things will never go back to those dark days. I mean, we do, as you know, have monoclonals. They've been evolving, Bevlimumab, which is the one we're using now. We've retired 3 others that, no longer work against these variants, the BA2 Omicron. We have the Pfizer drug, Paxlovid it's called, and we don't use it much, but we also have the Merck drug. And I think there are other drugs on the horizon. We have the boosters. And so we are in a better situation.
So let's separate those two. So the first bunch that you mentioned were drugs that are used for people who have COVID and may be at risk for getting desperately ill from it. Is that correct?
Yeah, the Paxlovid is primarily used for that purpose, although as the scarcity of it becomes less and less problematic, it will be used more and more for people who are at lower risk, and that's basically evolving as we speak. So in the beginning, you had to be 65 and have multiple comorbidities or a transplant patient, and now I think people are using it generally in anyone who has any significant morbidity, and that's not a problem. And yes, it dramatically lowers the risk of hospitalization if it's given quickly after the diagnosis. It lowers the risk more if it's given within 3 days, but it has some moderate benefit even at 5 days.
The monoclonals are antibodies that we actually infuse into people to help augment their own natural immunity. Yes.
The monoclonals can be used therapeutically, again, in a similar population. As a matter of fact, Bevlimumab is given by IV push, so it no longer even takes a half hour. It's a quick infusion. It is given intravenously. And we have a monoclonal called Evishield, which is given every 6 months to people who don't react to the virus because they are immune suppressed, or the few people who truly can't take the vaccine. And that's another, tool to try to prevent people from getting sick who don't have immunity and can't make it.
So far, we've discussed that the virus has evolved to be more contagious and, fortunately, just accidentally probably less deadly. And we now have a whole bunch of tools available for treating people who get sick. Let's talk about the vaccines. So the vaccines that are out there now were developed against the original Wuhan strain. Is that correct?
Yep, a virus that you can't find anymore, no matter how hard you look.
Are we, again, just lucky that those vaccines are still effective against the strains that are prevalent in the community now?
Yeah, we are lucky. Also, they're not nearly as effective, quite frankly. I think we need to be transparent about that, which is why we needed the first booster and why, we're pushing, at least in certain groups, the second booster. And I think we all know it's not a great match. There are new variant vaccines being manufactured. I think we initially thought that as these variants came up, it would be a quicker transition, but the reality is such that making hundreds of millions of vaccines and changing them regularly is going to be as quick as we anticipated. And both Moderna and Pfizer have plans to have a bivalent vaccine out by the fall that will contain a new Omicron variant as well as the ancestral strain, and that will, with little luck, be a lot more effective.
So bivalent means that it has two different kinds of proteins in there, or the RNA to code for two different kinds of proteins?
Yes, exactly. No different than, say, the typical flu shot this year has 4 different strains of influenza, 2A's and 2B's, but yes.
Yeah. Before we move on to kind of new vaccines, I just want to clarify a couple of things about the vaccines that are out there now. So they're not as effective against the prevalent strain now as they are against the original strain. How good are they in general?
Let's look at that. And, without having the ability to actually show you the data, I can say that if you get your first 2 vaccines, which, some people call, quote, fully vaccinated, then, within a matter of a few months, you've lost down to the low 30s at best efficacy against preventing infection. That being said, it still significantly decreases the chance you will wind up in a hospital or on a ventilator and dying.
Meaning, so you could still get like a bad cold, but it's not gonna kill you.
Yeah, although, as I say, at least 30 or 40% of our hospitalized patients now have been fully vaccinated, but it does decrease that risk and decrease the risk that you'll wind up on a ventilator or dying. It doesn't eliminate it. Mm-hmm. If you do get a booster, then it dramatically improves the chance that you won't be hospitalized. A huge difference. And, if you get a second booster, which is what just came out now, it's not as good as the first booster. By 2.5 months, you're back down to about a 29% efficacy, down from about a 65% within the first 3 weeks of getting it. So I don't want to, tell people that second booster is going to, be dramatic. It will certainly help for a matter of months, but its effect seems to be significantly declining after 2 to 3 months, which I think is the reason it was somewhat controversial and not being offered to everyone, and is going to not replace the need for additional boosters down the line, hopefully in the fall.
So that leaves the waters a little muddied, right, in terms of recommendations. So let's try to clarify that a little bit. I guess the FDA has just made the second booster available to people over the age of 50 who have at least some measure of increased risk. Could you just step through for our listeners who's currently on the list of eligible for a second booster?
Well, first of all, anybody at any age who's immunosuppressed, and I strongly encourage them to get it because those are very vulnerable people, and anything you can do is worthwhile.
So let's just define what that means. So who's in
anyone
that
over the age of 12 who's got a serious immunologic disease. There's a whole list of them out there, but it's the standard ones that you're all familiar with: immune modulating drugs to treat rheumatologic and gastrointestinal problems, transplant patients, uncontrolled HIV, patients on combination chemotherapy, hematologic malignancies, myeloma, the sort of usual package. And those people 12 and over should get a booster. Then anyone who's over 75 really should get a booster because they're the ones who clearly have the highest incidence of winding up in the hospital if they've gotten their first booster. And then anyone over the age of 50 may get it. I encourage people who have significant comorbidities like hypertension, diabetes, obesity, chronic pulmonary disease, and heart disease. There's no downside in getting it. Nobody has ever demonstrated that getting the second booster is going to hurt you or prevent you from getting a bivalent booster in the fall. They're not mutually exclusive. You don't have to decide one versus the other. So I think in those groups it's a very reasonable thing to do. And anybody else who's over the age of 50 who wants to get a booster that will at least transiently, significantly help in a time when COVID rates are going back up in New York.
Yeah, so I have 2 questions about that. So one is, I guess, a timing question. Meaning, if it seems like the durability of the improvement in immunity from these boosters is not that great, then should we be waiting a little longer and hedging more towards the fall when it's more likely that the virus will become more prevalent, or should we just get one now and then get another one in another few months?
I think it depends on the individual. If you've had Omicron in January, then there's no urgency for you to get that booster. I mean, one of the things that's clearly come out is that people with Omicron have decent immunity for up to 9 months, and it's hybrid immunity, meaning immunity from the natural infection, particularly Omicron, much more so than the others, as well as at least one vaccine after Omicron have very good and probably the best immunity of everyone. So if you're in that circumstance and you've gotten at least one vaccine in Omicron, I don't think you need to rush out. Regarding the timing of the other, it's a personal choice. As I said, I don't think they're mutually exclusive. So, I mean, I can speak to my own experience, which is rates are climbing. I really don't want to dramatically, cut it back on my lifestyle. So I'm getting a booster, and I plan on getting another one in the fall if it's available.
Yeah, and what about the original recommendation for the first booster was to get the same vaccine that you got when you had your initial series. Is there anything to suggest that recommendation should be different, meaning that if you got the Pfizer, maybe you should get the Moderna? And is there any benefit to mixing and matching these things?
Mixing and matching is perfectly permissible. Regarding the data, it's soft, and that's why none of these national agencies have made strong recommendations. There's a couple of papers out there that suggest that mixing and matching, particularly with Moderna after you've had Pfizer as opposed to the other way around, might be beneficial, but it's soft data at best.
If we step back from some of the details that we've just been talking about, it sounds like many people were infected with Omicron and have some degree of natural immunity. We can talk in a minute about what the percentage of the population has been immunized. We have better tools available to treat people. I mean, it sounds like we're in a situation where our whole relationship with this virus and with this illness is shifting to a new kind of model. Would you say that that's fair?
Yes, absolutely. I think it is a new model, and the model is going to be not hospitals filled with dying people, not overcrowded, urgent care centers, and life pretty much back to the way we know it for most people, but with intermittent flares of a virus that in fully vaccinated and boosted people will not cause dramatic harm to them. There's also still super spreader events occurring. I see them regularly, and there will be problems with many people getting ill at weddings and other venues where they're close together. It's still happening and will continue to happen. So I think you're right. I think life has moved on and we're in a much better relationship, but we're not, the virus is not gone.
Right.
And I do think that, the fall will be exactly 9 to 10 months from the Omicron, and that's when I would expect immunity will be significantly waning in a large segment of the population. And quite frankly, the most depressing part is that, roughly 50% of people have gotten their first booster, and only about 35% of adolescents have gotten a booster. And so we still have a vulnerable population that each month will become more vulnerable, which will lead to intermittent, interruptions of our society. And I personally see that we're going to have a almost, I hate to put this in political terms, but almost, two groups of Americans.
Yeah.
Americans that are constantly getting vaccinated and will be less sick, and groups that and there's some actually very good data from the CDC that demonstrates that that's already occurring, and the split is mostly between urban areas and rural areas.
Meaning that the urban areas have higher percentages of vaccinated people.
They're actually dramatically different. Ira, but yes.
Do you have some numbers, Bruce?
It's like 58% versus 38%. I mean, it's highly significant numbers of differences, and I think we all see that,
Is this the model that people speak of when they talk about COVID becoming an endemic disease as opposed to a pandemic disease?
It's exactly. I mean, people always relate it to flu. I would just always point out to them that it's a little different than flu. I mean, it's going to be endemic, but endemic in the sense that, unlike flu, it's not going to be strictly seasonable. It is associated with long-term sequelae. It does spread by super spreader events, all those things flu does not do. And flu really does occur, in 98% of the time, sometime between late September and April, and almost is never seen, after April, before October. And COVID's weird, it can do that. It can certainly spike in the summer.
I'm glad you brought up flu because it raises a question I've had about whether in the near future we're going to be co-vaccinating people, meaning you get one shot for both illnesses. Do you see that coming? Yeah,
Moderna has that trial with that. It's a little bit unclear whether this platform is going to be as good against flu, and that's, look, every investor is banking on Moderna to be a good flu vaccine. The COVID market is something you can sort of calculate, and it is what it is, but the flu market would be another huge home run if these platforms work, but it's not quite there yet. No one knows.
We've obviously been talking about what's been going on here in the United States, but COVID-19 has been a global pandemic, obviously started, as best we can tell, in China and spread around the world. What should we be thinking about or looking at or doing with regard to issues of COVID outside the United States, and how does that affect us?
Well, as you know, the Congress is, as we speak, cutting back on money to fund vaccines outside the United States. We've always been somewhat short-sighted, so I don't know that we're going to do a whole lot for the rest of the world. We've done a lot, but not that much. And, of course, China, I think, is the most interesting story because they are the only large country in the world that has had a zero COVID policy, and it is failing miserably as we speak. Yeah. There's no way you can control Omicron. So we will see a large outbreak. Hopefully that won't lead to other variants. The best thinking is that Omicron developed an immunosuppressed patient, who had been infected, because that's the site where these mutations are most likely to occur.
But I guess what I was driving at was, we're still very much linked with the rest of the world in terms of the ability of the virus to spread, mutate, come back and bite us. I'm just trying to make the point that we're not, I was going to say we're not immune, but poor choice of words. We're not isolated from what goes on outside of our shores.
Absolutely. These barriers that people have put up, in terms of travel bans, have been effective for a very short period of time. Their purpose, I believe, is to allow people to get ready, but they certainly, never prevented any serious spread from entering any countries, not a single one. The ones that had some success early on, the South Korea, Indonesia, Singapore, all failed miserably. Even New Zealand and Australia failed miserably as time went on, which is what we're seeing in China. And there's no way to hide from a virus like Omicron. There's no way you can hide from it.
Right, and the world is just too interconnected, right? I mean,
exactly.
We can't count on that to protect us. So what else should we be doing, either nationally or individually?
Well, I think a lot of the things we are doing now that we hadn't done before. We are much better at monitoring for these variants, and so we do know when they're coming. I know that BA3, for example, is now about 0.5% in New York. We see that data every week. BA2 is up to 60-some-odd%. So I think we are doing a lot more that was never previously done. That's a good thing. We are making these drugs available. Hopefully Congress will continue to make them available for free. That is a fight that is literally going on day by day in Washington as we speak. That's a good thing. I think from a infectious disease point of view and from a public health point of view, my biggest disappointment is the inability to get people to accept this vaccine. And I think most people who have not been vaccinated and have not been at least boosted probably aren't going to get it. I mean, I'm no longer naive and think that we can talk people into it. You can't. And that is, I think, disappointing, because I think that has led to a lot of unnecessary deaths, thousands and thousands of unnecessary deaths.
And what's your feeling about the future of all the other stuff we've been doing, masking, social distancing, avoiding crowds? I mean, it seems to me that people have just kind of had it with all of that. Is that?
Yeah, I don't think there's any doubt that that's the case. You walk outside and you can see it. And unlike some other cultures, Japan, for example, where people, are much more obedient and cautious about that, our society has decided that we're not going to do that. And, I have some thoughts, which is, look, not to get off topic, Ira, but our society tolerates 100,000 people dying a year of drug overdoses and 35,000 people dying of suicide and 25,000 people dying of gun violence and 700 mass shootings per year in which 4 or more people are killed. And we're going to tolerate somewhere between 100 and 250,000 COVID deaths per year. And that's just the way we're going to function. And that's the price we're going to pay and the health care costs associated with it. And that's going to be in the background. And that's what it's going to be going forward, because we could get that number a lot lower. We couldn't get it down to 0 no matter what we did. But like those other problems, we could get those numbers down a lot lower. But I don't think we're, at the present time, have the wherewith to do it.
Yeah, as much as I'd like to disagree with you and try to kind of leave with a more positive note, I think you nailed it. To me, it seems like people have just kind of, voted with their feet and said, I've had enough of this, and come what may.
Yep, exactly. And, and we'll live with it. Like, again, I think we're all going to die. I think the people who've been vaccinated and boosted are going to be just fine. They'll have intermittent interruptions in their life, but they'll be fine. And other people won't be quite as fine.
Last question here is, I think we've come to kind of an understanding of what this pandemic is going to look like going forward. But the next one is just around the corner, right? We're not done with pandemics in the generic sense.
No, I would just say 2 words. We were very lucky in many respects that this pandemic occurred so far from the last one. And I think all betting infectious disease people would always bet that the next pandemic will be influenza. It is an accident waiting to happen. We know multiple strains of influenza that are highly fatal but just have not become very easily transmittable are out there. They're in avian populations all the time. That will probably be the next one, and hopefully it won't be anytime soon, but as you know, the dice have no memory, and no influenza virus is thinking we're going to give people a break because they just had COVID.
I like that. The dice have no memory. Well, and I just to be clear, the last pandemic you were referencing was the 1918 flu pandemic, right? Right.
Yep.
Okay.
Yeah.
Well, Bruce, thanks again. I mean, I wish you had a more cheery ending here, but
I
think
not really bad.
Well, that's what I was going to say. There is good news here, right?
Exactly.
Yeah.
Look, if you're smart and you're reasonably intelligent and you believe in science, which I think we both do, we spend our lives with it, you can make very intelligent, reasonable decisions and have a great life. And quite frankly, I'm happy and I'm having a lot of fun.
Well, I'm glad to hear that.
Yeah.
You deserve it.
All right. Be well, Ira.
All right. Thanks, Bruce. My guest today has been Dr. Bruce Farber, professor of medicine at the Zucker School of Medicine, an infectious diseases expert, and the chief public health and epidemiology officer at Northwell Health. For more information about this program and to find past episodes, please visit medicine.hofstra.edu/wellsaid. Please subscribe to our free podcast wherever you get your podcasts. Our listeners are also welcome to send comments, suggestions, and questions to wellsaid@hofstra.edu. Until next time, I'm Dr. Ira Nash, and that's Well Said.